both screening as well as disease monitoring. And I think CellMax is closer to that goal because of their ultra-sensitive biomimetic CTC microfluidic platform. If you can have the video, we have a 2-minute teaser.
Haystack. Actually, it's harder. However, there are signs, like circulating tumor cells in blood, but they are very rare and present at fewer than 5 cells in a background of 1 billion cells. But at CellMax Life, we found the needle. Our circulating tumor cell blood test detects early stage cancer and precancer with 84 to 88% accuracy. And the world is noticing. Circulating tumor cells are detectable in the absence of circulating tumor DNA. While current liquid biopsies only detect cancer when it is advanced, the CellMax Life CTC platform is the only clinically validated liquid biopsy platform for early cancer detection. Conventional CTC methods are limited to detecting hundreds of cells in the blood when the disease is advanced. The CellMax Life platform isolates a single CTC in 1 billion blood cells found in precancer. This breakthrough technology has multiple applications. Across the continuum of care, from early detection to treatment selection and monitoring, our ultrasensitive CTC platform can detect and track cancer as it begins to grow, earlier than most other platforms. The platform requires just 1 tube of blood from a single blood draw. The proprietary surface coating on the microfluidic chip is ultrasensitive, picking up circulating tumor cells while leaving unwanted blood cells behind. A patented gentle air foam releases the precious cells, ensuring these are intact for downstream analysis, recovering intact CTCs in up to 90% of samples. Cancer is driven at multiple levels: DNA, RNA, protein, and epigenetics. Intact CTCs can be used to analyze cancer at all of these levels. Our customizable assays include next-generation sequencing of DNA and RNA on our best-in-class platform to detect multiple analytes, including MSI, tumor mutational burden, and germline mutations. Protein expression to detect PD-L1 and other markers of interest. Single-cell genomics, unraveling tumor heterogeneity, and DNA methylation analysis. The CellMax CTC platform is being used to monitor 16 cancers, assessing treatment response and early recurrence. CellMax Life holds 7 patents, is highlighted in over 30 publications and abstracts, and offers globally affordable, successfully commercialized tests. CellMax Life. Detect early, treat early, save lives.
So with that, as you can see, the platform is really sensitive and robust to capturing 1 in 1 billion cells in the blood in a 3 to 4 ml vial of blood. And so what that does translates in from a clinical applicability standpoint is that we can not only use it in the precancerous stages, such as we've done shown in adenoma detection in colon cancer screening, but also catch these tumors early on after treatment in metastasis and as well as treatment monitoring. So this is a study that I co-authored and we presented at ASCO GI earlier this year, where we showed that the So as you can see, in colorectal cancer patients, the CellMax CTC test was equivalent in sensitivity to all the other FDA-approved tests. But for precancerous lesions, that is the adenomas, it had a much superior sensitivity compared to the FDA-approved test. So what this translates to is that for the first time, we have a liquid biopsy or a blood test that can really detect adenomas in the blood and help guide patients towards colonoscopies. Because even today, there is only 40 to 50% penetration of screening colonoscopies in the US population. And that's partly because patients do not want to undergo an invasive test like a colonoscopy. This study is more relevant to this forum. This will be presented in an oral session at the AUA later this month in San Francisco. So in this study, the patients who were undergoing prostate biopsy and had a PSA in the gray zone of 4 to 10 underwent the prostate biopsy and had the CTCs enumerated through the CellMax platform. And what's interesting is that the platform count demonstrated that there was a very high sensitivity and specificity in these patients. And based on the study results, they were able to come up with a CTC score which took into account the total number of CTCs, the age, and the PSA. And this had a very high discrimination to determine which patients should undergo prostate biopsies. So more importantly, as you can see here, 9 in 10 patients who underwent prostate biopsies could have avoided getting those biopsies done. So this test can be translated and expanded to other solid tumors, such as the bladder and the kidney cancer. And the microfluidic chip has the ability to not just capture these cells based on EpCAM antibodies, but also other non-EpCAM based antibodies. So in many ways, this is a true liquid biopsy because once you have the ability to capture these CTCs from the blood, you can then do a whole generation of molecular and genomic profiling on these cells. As you can see here, you can determine the methylation, you can do single cell sequencing, you can do genomic instability, as well as NGS. This is another study that was presented at AACR this year in non-small cell lung cancer, and this was for patients who had PD-L1 expression. And as you can see, the CTCs detected PD-L1 expression across all stages of cancer. Also, interestingly, there was a high concordance of close to 90% for patients who had these PD-L1 expressed on their CTCs, and the concordance was determined by IHC in the tissue samples. Also, there were 9 patients who had PD-L1 expression in their CTCs but did not have a positive IHC for these PD-L1s. So in addition to being able to do the CTC capture and CTC enumeration, they also have the ability to do NGS for somatic mutations, not only for the standard for analytes, but also for MSI. On top of that, they are being able to do the germline NGS testing in their CLIA accredited lab. So essentially, as I enumerated before, the CellMax platform is a true liquid biopsy platform which has the ability to not only help with early diagnosis, but also be used throughout the care continuum of these patients in their monitoring and progression of their disease, and be able to do the molecular and genomic profiling in their captured CTCs. Thank you.
It's fascinating. So, do one of the issues is finding, a cancer cell and not knowing if there's a primary. There was studies done a while ago or years ago in breast cancer where they did bone marrow biopsies after adjuvant therapy, and there's a percentage of patients who had positive breast cancer cells in the bone marrow. And when they followed those patients, they had a much higher risk of relapse, but all of them didn't relapse.
Same as been shown in prostate.
Yeah, so The question is, when you look at when you're so sensitive, you're going to find patients who may never have clinically relevant disease. So is your strategy, I mean, do you think, especially looking for somebody who doesn't have disease, is it to say, if I find no cells, I don't think this patient needs a colonoscopy or a prostate biopsy or anything else. Are you going to say that I can, kind of not do a CT scan for chest or cats or for a lung cancer? I can avoid doing all those other biopsies or scans, if you don't find it. Then if you find it, then maybe I can biopsy or not. So what's going to be your strategy going forward? Is it to avoid doing those other tests, or is it to, know the ones that I'm going to, do more?
Well, that's a great question. So at least in the colon cancer space, from a screening standpoint, as I mentioned, there is still under penetration of the gold standard test, which is an invasive colonoscopy. And so when you're trying to incentivize patients to undergo a screening, many of them do not want to go through that, even a stool test for that matter. So this really allows patients, incentivizes patients to come into the system to get a study. Then if it is positive, they will undergo a colonoscopy. But there's a whole chunk of patients. So from an ACO standpoint, the Kaisers of the world are really interested in this approach, where can we replace expensive invasive tests with a cheap, cost-effective blood-based test.
Yeah, so they say if that's negative, they don't need to go through any colonoscopy.
Exactly.
How are you going to address the issue of lead time bias in this? In detecting cancer and then looking at their survival? I mean, there may be a huge lead time bias in that.
True, but at least in the colon cancer screening space, there have been studies to demonstrate. So there, in the case of CTCs, if you find a positive CTC in patient with adenoma, they are going to undergo a colonoscopy, but this is going to be for the average risk population. So they are already, the colonoscopy is already indicated in those patients. So the lead time bias may not be that relevant.
Maternal testing, over age 35, they are developing this test called Signatera, and they presented some pretty amazing data recently. They also have a Nature publication, specifically in bladder cancer. They've showed that with looking at circulating tumor DNA, they can detect after therapy or after cystectomy recurrence up to, an average of 9 months prior to first radiographic imaging. And similarly, they can look, I'm in the field of cancer vaccines, so we're looking at tracking antigen-specific T cells and antigen expression, so they can help detect, the presence of antigen-specific cells. But I don't know if you guys are following them. But they've also presented in colon, bladder. They've also done some studies where they have shown that just even prior to cystectomy, if patients' circulating tumor DNA is analyzed, they can predict with pretty high accuracy who is going to progress significantly faster after cystectomy, after definitive therapy, as opposed to others. So,
yeah, I think CellMax has done a study in patients with colorectal cancer, where they have found the CTC count determines or helps with guiding the treatment as well as prognosis.
right. But maybe linking it to radiographic recurrence is a good way, because often that's what we want to know, right? Radiographically, we may not be able to tell, especially in the era of checkpoint inhibitor therapy, where a lot of the neoadjuvant studies are showing us that radiographically it may look like the tumor is there, but once you go in and you do a resection, the tumor is actually quite different.
So you mentioned the sensitivity. And does it mean now that you find certain tumor cells in 100% of prostate cancer patients, in 100% of kidney cancer patients or bladder cancer patients? Can you elaborate on those numbers, if you have them?
I don't have the details of the study. I'll refer you to the AUA abstract.
Are you able to determine the site of origin of these CTCs with tissue-specific methylation profiles, and have you looked at all at determinants of aggressiveness based upon the tissue biopsies that can be used as markers to predict whether an aggressive versus non-aggressive tumor is present? Because for us, we don't care about detecting prostate cancer in general. We just want to find the ones that need to be found.
So I'm not familiar, Padma, I don't know if you have the answer to that question.
Yeah, that would help you eliminate the noise of the non-mutated, relatively benign cancer cells. You'd want to look at Tempus rearrangements. You'd want to look at P53 and probably RB.
My experience, patients who relapse rapidly after prostatectomy non-normalized PSAs.
Mm-hmm.
There have been a huge number of companies developing CTC-based technology with very few commercially available tests. In fact, one, maybe or two. And it seems that the strategy has been to go completely wide open with multiple diseases, multiple disease states, multiple clinical questions, and multiple assays laid on top of the CTC platform. And I think there could be some benefit to really narrowing down the clinical question that you're going to go after and nailing that question.
Thank you.
Thank you.